The research question we decided to pursue involves deracializing healthcare and whether or not zip codes serve as a better medical proxy compared to race. So what is a medical proxy? Lewin Wang, a law professor at the University of Pittsburgh and well-versed in the research of racism at varying degrees, defines the word proxy in the context of race as a means to depict the innate manner that race influences decision-making in medicine. Race-based medical proxies become a problem since it leads to racial profiling, such as when African-American NFL players try to seek financial aid for brain surgery, and when African-American individuals seek employment.
It is hypothesized that zip codes will serve as better medical proxies than race due to the prediction that it will yield more precise medical data from a sample size. We had come to this hypothesis due to our understanding that zip codes play an important role in determining one's access to greenery, quality of food, education, and other factors that affect standard of living. Research in places like NYU proved just how impactful zip codes can be in determining a person's health. When NYU had evaluated life expectancies in 500 major cities, they found stark disparities in life expectancy between different neighborhoods in these cities. In some neighborhoods, life expectancy was at least 20 years lower than neighborhoods found just blocks away. In even just Jersey City, this is notable, as different neighborhoods experienced vastly differences in temperature during the summer months due to local differences in greenery.
A little bit about the background of race-based medicine. It has been used as early as during the antebellum period in the United States to justify African-American enslavement. Samuel Cartwright, a physician and slaveholder from the southern United States, was the first to implement spirometry and show the quote-unquote deficiencies African-Americans had when their lung capacity was lower compared to their white counterparts. These spirometer results were found in Thomas Jefferson's publication of Notes on the State of Virginia of 1832, where he stated that the enslavement of African-Americans would vitalize their blood and therefore improve their quote-unquote pulmonary deficiencies. Consequently, race correction and race proxies are now acceptably scientific practices. However, zip code medical proxies appear as promising replacements according to past research, since the health factors that may be attributed to race may actually be caused by the effects of race, such as how different races may have varied living conditions. For example, Ayanna Popescu, a well-acclaimed researcher with a dual PhD in operations research and in applied mathematics, discovered that Black identifying men had the lowest survival rate amongst Black and white men and women when analyzed under the pretense of racial residential segregation in a metropolitan area, because Black men fare worse in the labor market that consume an urban city and are much more affected by incarceration, which not only imposes tremendous negative health effects on the individual himself, but also his family and community as a whole. Popescu proposed ameliorating the differences in living conditions between Black and white neighborhoods. These findings prove that the race of the individual had not caused differences in health outcomes, but the differences in geographic living conditions imposed by society's biased treatment towards certain races. This brings me to the gap in research we aim to address. There are currently limited efforts being made to expand population health, and much more financial support is currently being invested into precision medicine. Thus, this paper will hope to fill in the gap in which research pertaining to population health still lags behind. While there is similar research found comparing race to zip code in the medical field, it focuses on the effect race and zip code have on individuals seeking healthcare and their inclination for treatment, as opposed to observing how zip code compared to race can serve as a better proxy when diagnosing an illness.
When considering how to conduct our experiment, we were first concerned with what device we would use, whether it would be a spirometry or a pulse oximetry device, as this would have an important impact on our results. One of the initial problems we came across during our initial investigation was the prevalence of racial bias in both devices, as the spirometry takes race into account during its calculations, while the pulse oximetry device is sensitive to skin pigment due to the use of red infrared light to gather its calculations. The secondary problem we had found was the limitations the pandemic would place on us due to sanitary concerns. A spirometer requires an individual to blow into the device, and this would require the replacement of the tube used to blow air through it, which would also be an issue due to financial concerns. But a pulse oximetry only requires a person to place their index finger into the device, which would make sanitizing this device a much more feasibly realistic process. These factors ultimately led us to use a pulse oximetry device in order to gather data for our experiment.
As for the procedure, the experiment required 100 voluntary high school participants between the ages of 14 to 18 years old, each test subject placing their index finger inside the pulse oximeter device on a flat surface. After ensuring the oximeter had been sanitized, the same model of the device had been used for every individual tested and maintained as a controlled variable. Upon retrieving their blood oxygen level, each participant was then required to fill out a form asking for their identified race, gender, age, and zip code. The blood oxygen levels for all 100 participants participants were organized into tables and bar graphs according to each of the 4 races in each of the 4 zip codes observed, namely Black/African American, White, Asian/Pacific Islander, Hispanic, and the zip codes 07304, 07305, 07306, and 07307. The average value for each of the 8 resulting groups of data was calculated for and graphed as a line on their designated bar graphs. For each of the 8 groups, the residual, or the distance between each participant data value from the average, was calculated for and recorded. The average of the residuals for each of the 8 graphs was also calculated. The average of the individual residual averages collected for each of the 4 data sets based on race was then calculated by finding the sum of the average residuals and dividing by the number of races observed. This number was then compared to the calculated overall residual average for blood oxygen levels arranged by zip code. The calculated number closest to 0 between the two would serve as a more accurate measurement and thus determine whether correcting for race or zip code fares better in the process of collecting medical data.
Data Table 3. Pulse oximeter residual data organized by race and zip code. This data table organizes all of the individual residual values that we had found while conducting our experiment. Data shown in Table 2 and Data 4 represent the average residual values organized by race and zip code, as well as the average results by race and zip code of the pulse oximetry reading, respectively. The graphs shown represent each respective participant's blood oxygen levels, along with the average reading for each group, yet tested represented by a red line. This is organized on our slides by race and then by zip code. The final 2 graphs show a scatter plot of all our data points, as well as the average residual value of each group tested side by side. When first analyzing our data, we sought to determine the accuracy of the data we had pulled, and so we researched a similar study conducted by Joshua Elder, an emergency physician at UC Davis who had found that most students within a similar high school age range to our participants had pulse oximetry readings of 97 to 100%. Which the majority of our participants fell under. At first glance, the blood oxygen levels retrieved from 100 participants in Graph 1 appear to show no correlation, since the data points are scattered and exhibit no directional trend. Thus, the data was further organized into 2 sets of 4 groups, first according to the 4 observed races and then according to the zip code residency. When looking at the average blood oxygen levels from each zip code and comparing it to the average blood oxygen levels from each race, the averages retrieved from organizing based on zip code were higher overall. Data Table 4 showcases that the average residuals of blood oxygen values grouped according to zip code yielded an overall lower average absolute value, with the average zip code residual being 3.5% lower than the average race residual value. Zip code proves to serve as a better proxy because the closer the residuals values were from 0, the less variability, thus increasing the precision.
Earlier in the experiment, it was hypothesized that zip codes would serve as a better medical proxy as opposed to race, since more precise medical data would result. The data has proven the hypothesis correct because rearranging blood oxygen levels to correct for zip code produced lower overall residual difference, or a value with the lowest absolute value, when compared to that from race correction.
Accurate medical proxies for the purpose of diagnosis have always been needed in medicine. Their role is imperative in comparative analysis and allows for more efficient methods of diagnosis. Currently in medicine, race is still widely used as one of the most accurate forms of medical proxy, though it is already widely accepted that this only continues to limit the potential for better diagnosis. Existing medical practice that utilize race-based data within their calculations could benefit from zip code-based samples instead. One such area in particular where the need for better data sampling is apparent is in pulmonary function tests, which determine lung function while using race to adjust its calculations. Currently, this disproportionately miscalculates the lung function of those of East Asian descent due to its race-based data usage, which is why the greater correlation found with zip code rather than race in something as simple as an individual's blood oxygen reading is something of significance.
Some limitations identified were the aforementioned race correcting of the pulse oximeter due to the use of light and skin pigmentation of various individuals. Additionally, volunteers were not asked whether or not they had lived in a previous zip code prior to their current one. Living in a location with a different zip code may create shifts in the individual's health due to environmental changes between one zip code to another. A participant who has lived in various geographic locations prior to their current one may interfere with the precision of their blood oxygen levels when compared to the blood oxygen levels obtained from other individuals growing up in the same neighborhood.